Given her history of prior laparotomy, she was a poor surgical candidate and was referred to us for cholecystoduodenostomy.
The good news is that the gallbladder is likely to be fairly adherent to the duodenal wall or the bowel wall. The bad news is that cholecystostomy tube, that external drain, has been in place now for, 5 months? And so the gallbladder is likely to be very contracted. And her gallbladder is packed with stones. So we may not have a lot of room or any room to place our axial stent. It's stone, it's large, and it's shadowing. You can measure out the size of the stone here. So just to give you an idea of what we're dealing with, this is about 1.1 centimeters. And then here you can see the gallbladder wall. This is the duodenal wall. We have the liver over here. So the challenge now is going to be to create a fluid-filled space to allow us to place the axios. And you can see the needle there, right? I'm moving it back and forth so you can see the tip nicely right here. And I've got to get this tip here, right here in this little teeny 2 millimeter space and hope and what I'm going to do is thrust it in there because I'm thinking there's a lot of scar tissue here. So let me just dial in I like to thrust. So I'll dial in about 1.5 and just thrust this in there. All right, so I'm in something, right? And as Jeannie, my assistant, the nurse, injects here, we're going to see if it expands that space. All right, so Jeannie, if you can please start to inject. And I'll first start just looking with EUS. Good. I'm going to come out, so all of this has to happen very fast. I'm out. Lock this. You see the stones are already moving. My position. I have an assistant holding my scope here so I do not lose my position. And hold the scope, please. And, all these things you do need to do. You need to measure the distance interpoles, but this will be under 2. If you can feed that in, because it's all slippery. This is hydrophilic coated. This is the hard part because I do not want to lose my position. Hold this, please. And the key is don't panic. Don't get rushed. Take your time. Look, and don't go switching back and forth between fluoral. Just use fluoral if there's some information you absolutely need. All right, so now I'm just snugging up a little bit more. Okay, that's good. Now I lock. Now I'm locking the black hub. And now I'm going to complete the deployment of the proximal flange in the working channel. And I have my eyes glued to the EUS to make sure that that distal flange doesn't start migrating forward, start pulling out. So now I'm pulling. It's a lot of force here because of the torque. We're in the duodenum. Remember, there's a big U-turn. It's like doing this in retroflexion. That's how it is. Okay, now I have the proximal flange deployed in the working channel. I'm going to push out the proximal flange. You see it? There it is. Pushing it out, and boom, it's out. I'm not dilating this tract. I'm going to leave it. I'm just going to put a double pigtail. I'm going to let the axials dilate this tract on its own. I don't see the urgency that I have to go in there now and look around. So I usually don't dilate unless there's a reason to dilate.